So good afternoon, ladies and gentlemen, and warmly welcome you on to the cancer treatment consultation from Asia leading expert. My name is Casey Thung Huyen, and it's my great honor to be the host of our event today. So, ladies and gentlemen, this workshop is organized by FPT Long Châu and the IHH Healthcare Group, and is a great chance to address queries surrounding the topic oncology, an issue that I believe that everyone who joining in our event today is really interested in. So with our distinguished expert in the field of cancer treatment, we will share together medical knowledge to prevent and how to treat this disease. So as we all know, cancer remains one of the most critical health issues worldwide, implicating millions of lives and demanding our attention. Therefore, finding solutions to combat this disease is of utmost importance. So, ladies and gentlemen, at today's consultation session, we are pleased to introduce two leading experts from Asia in the field of cancer treatment, both hailing from Singapore. We would like to invite the first speaker to stage for today's consultation session. So please allow me to introduce him with great respect. Mr. Jarrod Lee, Senior Consultant, Gastroenterology, Mount Elizabeth Novena Hospital, Singapore. So Dr. Jarrod Lee has made significant contribution to the field of biomedical research, particularly in improving cancer immunotherapy. He has conducted extensive research in developing new cancer treatment methods. Dr. Lee has received numerous prestigious awards, including the Young Investigator Award from the American Society of Clinical Oncology, ASCO, for outstanding contribution to cancer research. And now, please join me to welcome Dr. Lee to step onto the stage to begin the session on the topic gastrointestinal healthcare and screening for digestive system cancer. So welcome, Dr. Lee.
Thank you for that kind introduction. I'm very happy to be here in Vietnam today to talk about one of my pet topics, one of my favorite topics. Today I'm here to talk about digestive cancers, and I want to talk about prevention and early detection. If you can prevent or you can detect early, then it would be so much easier for all of us. I am from Gut Care, and I'm going to just spend the next few slides just introducing a bit about myself. Gut Care was founded in 2014, and we started in IHH. Without IHH, there would be no Gut Care. And we are very grateful to them for allowing us to build something. And today, we are Singapore's first and largest digestive group practice. And in each of the subspecialty areas, we have regional authorities. Today, we are a recognized brand in Singapore. We are recognized by the public hospitals, by family doctors, and by patients. And we have a whole string of mainstream and healthcare awards. Today, we have 6 clinics in 6 private hospitals, and we have 7 doctors in different subspecialties. We also have a very strong digital presence. And these are the doctors that are with us now. Let me go straight into the topic that I'm here for. I want to talk about digestive cancers. How do we prevent them? How do we detect them early? Why are digestive cancers important? These are the top 5 cancers in Vietnam. And I want to focus on number 4 and 5, stomach cancer and colon cancer. And you can see in Vietnam, these are the number 4 and 5 cancers for both male and female. Let's start with talking about digestive symptoms. There are many people who say, hey, if I'm feeling fine, why should I see a doctor? If I have cancer, won't my body tell me? Well, it's a common problem. The problem is that digestive symptoms are so common. Everybody gets digestive symptoms. About 20 to 40% of adults will get some sort of digestive symptom every year. Yesterday, I was eating a lot of bun cha, and in the morning, I felt a bit off. Does that mean I have early cancer? So if you just rely on digestive symptoms, too many adults have digestive symptoms. All of us had it. And the question really is, are the symptoms reliable? And more importantly, is it too late to wait for symptoms? Is it too late to wait for your body to tell you that something is wrong? And let me illustrate why. This is a normal colon. And you can see when the colon is empty, this is what it looks like. This is what I see every day when I do a colonoscopy. What about this? This is an early cancer. This is stage 1 cancer. And you can see that at stage 1 cancer, there's nothing blocking. How would you feel a stage 1 cancer? You can't. The function is normal. The colon moves as per normal. How about if you waited a bit longer? This is a stage 2 to 3 cancer. And perhaps you may have some symptoms at this stage. But for many, many people, they will not feel anything. Why? Because you still have more than half the colon that is open. And so you won't get any symptoms. You won't have pain, you won't have diarrhea, you won't have constipation. But you are walking around with a stage 2 to 3 cancer. And if you still didn't see a doctor at that stage, then this is what happens. Now, at this stage, you will have symptoms. But this is already a stage 3 to 4 cancer. And if we waited for our body to tell us that something is wrong, then this is what I will be seeing if I did a test at that time. And the outcomes when it's so advanced are really not in our favor. In reality, the commonest symptom in cancer is no symptom. That's the reality in digestive diseases. And cancer can affect anyone, even young patients like this. The youngest patient I had with colon cancer was only 19 years old. The commonest symptom is no symptom. There's a myth that cancer is often genetic and we can't do anything about it. So why bother? If we are going to get cancer, we're going to get cancer. There's nothing we can do about it. But the fact is this, 40% of cancers can be prevented. And in digestive cancer, this is even higher. People talk about, can diet prevent cancer? Well, there have been many, many diets proposed. Every day I hear all sorts of diets that patients tell me about. But it is very hard to prove how a diet can prevent cancer. And today, the evidence is not really there for us to promote any particular diet. So what is proven? If you can't use diet to prevent cancer, what can we do? Well, the WHO says that 30 to 50% of cancers can be prevented through screening or pre-cancer treatment. And we know today that if you go for colonoscopy, you can reduce your colon cancer rate by 70 to 90%. 70 to 90%. That is a huge number. We know that gastroscopy can increase early cancer detection. And that Helicobacter eradication, this is a germ that attacks the stomach. If you eradicate this germ, you can reduce stomach cancer by 50 to 60%. And if you look at these numbers, you can see why it is important for us to understand that cancers can be prevented. Developing a stomach cancer is a very complicated process. And you can look at the many stages that you see here. And this entire pathway usually takes up to 20 years. So why do we have to wait 20 years to detect the cancer when we can detect it in the 20 years before it turns into cancer? Likewise for colon cancer. Again, it takes 15 to 20 years for something to grow in the colon and turn into cancer. If I can pick it up before it turns into cancer, I can prevent colon cancer. And the studies show that this is effective in 70 to 90%. I want to talk a bit about digestive endoscopy. And thankfully, this is not what we do anymore. These are the first first generation of endoscopy. Today we have come a long way. The two main tools that we use are the gastroscopy, where we look for stomach cancer and stomach cancer early detection, and colonoscopy, where we look for colon cancer, as well as colonic polyps that can turn into cancer. Today, endoscopy has become a very, very technologically advanced procedure with many, many different types. And it's actually quite confusing to go through a chart like this. Suffice to say that for experts like us, we know exactly which mode to use to be able to detect that early cancer or even to prevent it. This is an example. If you look at the yellow box, you can see something there that doesn't look normal. And if you look at the blue box, you can see how we can magnify the area. And if you look at the green box, you will see that there is only one area that looks like it might be cancer. And in the red arrows, you will see that there is a spot of cancer. This spot is only 1 millimeter in size. 1 millimeter. Today, our technology allows us to pick up a 1 to 2 millimeter cancer in the stomach with great accuracy. And you can see how the technology helps us to do this. This is another example. If you look at the white box, you can barely see anything. But when you magnify it and you look at the blood vessel patterns, the microarchitecture, the vascular abnormalities, you can see the earlier stages of cancer. Today, our technology allows us to see cancer as it happens. Likewise in the colon. In the top polyp, you see early cancer development, and if you magnify it, you can see how right in the middle, all the blood vessels disappear and there's no architecture. This is how we detect the earliest cancers. This is how we detect things that may grow into cancer. And our discipline has grown so much in the last 30 years. I want to talk a bit about colon polyps. Colon polyps are the precursor of cancer, and it takes about 10 to 20 years for a polyp to finally grow into cancer. So to prevent colon cancer, I need to look for a polyp before it turns into cancer and take it out. And I can do it at the colonoscopy itself. Polyps come in all shapes and sizes. And today, our science allows us to look, detect, and more importantly, remove polyps of any shape and size, anywhere in the colon. And it's important that we do this properly. It is important that when we remove one of these polyps, that we remove it completely to prevent the cancer. If we don't remove it completely, what's left behind can still turn into cancer. Today we have so many different techniques, and there's a large difference in difficulty and the expertise required to remove these polyps. We like to stress that doctors should only remove polyps that is at their skill level rather than something that is beyond what they can do. These are the basic techniques. But today we have a lot of advanced techniques. We can use it, what we call hot EMR, cold EMR. I can even do underwater polyp removal today. And this is part of the wonderful variety of techniques and tools that we have in the year 2024 to help people to prevent cancer. So these are just some of the examples. You can see a big polyp here. And this is the advanced resection that we use to completely remove the polyp and avoid the cancer. A polyp like this can turn into cancer at any time. This is another technique. We call this the cold EMR technique. You can see that the polyp is very difficult to even see with a normal lighting. But with the technology that we have, we can see it very clearly. And more importantly, we can remove it clearly. These patients, when we do these techniques, they go home immediately on the same day. In fact, they go home 1 hour after I finish with them. That's how fast we can do it. This is another example of how we remove things using the new underwater technique. So it's like scuba diving. We can remove things underwater now, and it's really very neat. This is another example where a polyp may have a very, very long stalk, and we tie it at the base, and we can still remove it in one piece. So quality matters. You know, I like to say that everybody plays soccer. In Singapore, everybody is playing soccer. But, you know, there's only one champion in Southeast Asia. Singapore team gets beaten 7-0 by Malaysia. the doctor is very important, very important. Quality does matter for us. And we know that 15 to 20% of cancers are missed by colonoscopy today. So not all are the same. 1 out of 5 times a doctor that does a colonoscope will miss a cancer. And the polyp recurrence rate can be as low as less than 5% or more than 90%, again, depending on who does your colonoscopy. So quality really does matter. And we know that the chance of dying from cancer can vary by up to 100%, depending on the doctor. And today, there's a lot of emphasis on quality measures, KPIs, key performance indicators. We want to make sure that the doctors doing colonoscopy, gastroscopy have met a certain standard so that we can prevent that cancer. So these are just some examples that we see on a day-to-day basis. Doctors that in Singapore may have done a colonoscope 1 year ago, and perhaps you may see something there. You can see how easy it is to miss the problem. Can any of you see where the growth is? Now, if we change the color, you can start to see something very flat at the bottom. And this is just at the entrance to the appendix, so very difficult to see. And we can use an underwater technique, and we can remove it quite easily. This is one of my patients, and today, 1 year later, the polyp has no recurrence. Another example on how difficult it is to detect these polyps. You don't just go for a colonoscope. This is a patient of mine that had a colonoscope done 2 years ago. And again, where is the polyp? Where is the polyp? Now, if you start to look very carefully, change the color, you start to see something. And you can see that there's something large and flat in that area. And when we change the color with advanced imaging, you can see more clearly that there's something very flat. And today, we can remove them with very neat techniques. You can see how we use a EMR technique to remove the entire section. And this patient actually had several of these large ones, not just one. Some doctors, they do detect the polyps and remove them. So this is an example where a doctor tries to remove a polyp, tries to clip it shut. But when we go in 1 year later, you can see the scar, but the polyp is still there, inside the scar. And it's a lot harder to remove it once it has been removed partially. But we can still do it these days. The technology allows us to remove even polyps that are incompletely removed. Helicobacter pylori. Vietnam has one of the highest rates in the world. And this germ can cause a lot of stomach problems. It can weaken the stomach, it can cause stomach ulcer, and it can cause stomach cancer. It is the strongest risk factor for stomach cancer. And it is estimated that 60 to 70% of the general population in Vietnam has this germ. Now we know that eradicating this germ will reduce the stomach cancer risk by 50 to 60%. But it's very difficult to treat. Very, very difficult to treat. And a lot of patients will tell me, why bother? It is so difficult to treat. Everybody has it anyway. It doesn't make a difference. Well, the reality is that there are many new treatment options for us today. And our eradication rates can still be above 90%. And so give the doctor a chance. We can eradicate this today with a lot of new medication and new techniques. And we can reduce the stomach cancer rate by 50 to 60%. This brings me to my take-home message. Digestive cancers are common in Vietnam. They are the number 4 and number 5 cancers. Symptoms are not reliable. This is a very important point for the audience to remember. If you rely on symptoms, you are waiting for advanced cancer. These cancers can be prevented. They can be prevented. Why do you want to get cancer if you can prevent it? And quality is important. You have to choose your doctor wisely. This is a picture from me more than 10 years ago. I was invited by the gastroenterologists in Vietnam to speak at their annual scientific conference, and I'm still talking about the same topic today. I hope this little talk was useful for everyone. Thank you.
Many thanks to Dr. Jarrod Lee for your wonderful and practical information to all of us. So, ladies and gentlemen, moving next, we will come to a talk with Dr. See Hui Ti, Senior Consultant, Medical Oncology, Parkway Cancer Center. So Dr. C was previously a consultant in medical oncology at the National Cancer Center, as well as a visiting consultant at the KK Women and Children Hospital, KK8, specializing in adult breast and gynecologic cancers. She worked at Queen Elizabeth Hospital in Birmingham, UK, before continuing her internal medicine training at the Singapore General Hospital. So Dr. See Hui Ti is a member of the International Gynecologic Cancer Society, IGCS, American Society of Clinic Oncology, ASCO, and the Singapore Medical Association, SMA. She served as an executive committee member of the Singapore Society of Oncology from 2001 to 2007. And now, please welcome Dr. C to step onto the stage to begin the session with the topic Cancer Prevention and Update on Advanced Treatment Methods. Warmly welcome.
Thank you very much for this kind introduction. And I have approximately 20 minutes to share on the entire of cancer care that we know as of now, and a lot of things have changed in the last 20 years. So I titled this, All I Need to Know About Cancer. In this next 20 minutes, I hope to share a little bit about the concepts of cancer prevention for all the cancers that we can treat in the world right now. So first question is, most people will want to ask, what causes cancer? How come in certain countries there are more cancers than the others? So we know that cancer is caused by formation of what we call free radicals. That means damage to the DNA from pollution, from smoking, specifically from smoking. And permit me to disagree with Dr. Lee that the diet has no issue with causing or prevention of cancer. The diet is really important when it comes to causing cancer and prevention of cancer. So if we looked at statistics, tobacco, which is smoking, is the number one cause of cancer. The second one is diet and activity patterns. What we eat and what we do on a day-to-day basis will have great impact on what we can do to prevent and to treat our cancers. Alcohol being the third one, and microbial agents, which is infection from viruses. But cancer takes 15 to 20 years to develop. What I do today will prevent my cancer 20 years down the road. When I get cancer now is because of what I did 20 years ago. So many patients change their diet only after they get cancer. And I'm afraid that's a little bit too late. So let's look at the overview of the burden of cancer in Vietnam. Total population, well, almost 100 million. The top cancers are liver cancer, and the mortality, which is the death rate, is also from liver cancer. Lung cancer being the second, stomach cancer, and then breast cancer. So for liver cancer, of course, we will share later that the causes is hepatitis B, hepatitis C, and with vaccinations for individuals who are born beyond 1960s, they're all vaccinated with hepatitis B vaccination. And now with screening, we can definitely detect hepatitis B early, and carriers can be given treatment to prevent hepatitis B that is active and therefore prevent cirrhosis and therefore liver cancer. Lung cancer, unfortunately, is still due to smoking. And stomach cancer, as Dr. Lee has shared, is due to infection. So all this is largely preventable. In the statistics all over the world, according to the American Cancer Society, we have a 1 in 3 chance of getting cancer in our lifetime, which means that every one of us sitting here, there's a 1/3 chance that we may have cancer. And 3 out of 4 chance that our family is affected by cancer. My mom has breast cancer and has thyroid cancer. My grandmother had breast cancer, but it doesn't mean that I'm a genetic mutation carrier. It is maybe due to their activity and lifestyle. So we all like to eat delicacies of food. We like to eat preserved food. We like to eat pickled lettuce. But all this is associated associated with all the cancers in the GI tract, from the gut cancer, from the nose cancer, especially if we eat this as a very young person at the time that we're weaning off our mother's milk. Of course, carcinogens as smoking, betel nut chewing, and other cancer-causing chemicals in the pollution can also cause cancer. Mold in peanuts, aflatoxin in the oil that we use to fry our food, all this can also cause liver cancer that is not related to hepatitis B. And of course, with good potatoes, bananas, chicken, we make it into carcinogenic or potentially carcinogenic food by char grilling it and maybe barbecue, and we make it potentially carcinogenic. So I am more than happy to share these slides with everyone sitting here, and this talk will be broadcasted. I hope that you can share this with the rest of your family and friends, because there is a lot that we can do to prevent cancer, and it starts from the young. So as I mentioned, viruses can cause liver cancer. With hepatitis B vaccination, we can largely prevent that. Bacteria can cause stomach cancer, and with screening and treatment or an eradication of H. pylori, we can reduce the risk of stomach cancer. And metabolic cancer, this is the part about the diet and the lifestyle. Metabolic cancers means that if I am big, if I have a lot of insulin in my body, I can induce cancer by making potentially carcinogenic cells more active. And if we look at this list, this is a graph of the different types of metabolic cancers, meaning that the bigger size we are, the more heavier we are, the more likely a man is to get fatty liver and liver cancer in the very long run, colon cancer, rectal cancer, and pancreatic cancer. So clearly, also in Singapore, there was a study that was done some time ago to look at if a person drank more than 2 carbonated, sweetened soft drinks a week, it increased the risk of pancreatic cancer by 87%. For women, it's worse. For women, if we are obese postmenopausally, meaning if we are big size and we're heavy postmenopausally, there is a higher risk, a much higher risk of getting womb cancer, pancreatic cancer, breast cancer, colorectal cancer, liver cancer, ovarian cancer, so on and so forth. So many of these cancers are definitely related completely to the way that we eat and the way that we move. So have we shown that there are some food that is associated with the lower risk of cancer? Yes. We have shown that vegetables, garlic, ginger, fish, and a plant-based diet is largely associated with a decreased risk in breast cancer, prostate, lung, colon cancer, so on and so forth. But this takes 20 years to develop, meaning if I already have cancer, by changing to a vegan diet doesn't make the cancer easier to treat. But if I am not diagnosed yet and I'm surrounded by good food or plant-based diet, I can choose to eat plant-based in my early days, in my teenage years, to prevent breast cancer when I'm in my 40s. And if I change my diet when I'm in my 40s, I can prevent the risk of cancer when I'm in my 60s. It takes 20 years to change this diet. But what about supplements? Most of us like to eat what we eat, smoke what we smoke, and then say, I'll just pop a pill to prevent cancer. Studies have shown that by taking a supplement of beta-carotene or high dose of vitamin B12 actually increases the risk of a smoker getting lung cancer. Why? Because if there is already a pollutant or a carcinogen in the body, then by protecting them with high-dose multivitamins, it makes them stronger to the body's immune system that can potentially kill it. So supplements don't help. It is still down to a good diet and exercise. Exercising any types of exercises, as long as you keep a physical activity. We eat everything, but in a small measure, meaning there is nothing that we cannot eat, but we must eat them with responsibility, especially if it's sweet or high fat. So what about people who have a very high risk of cancer? If my mom has cancer, my auntie has cancer, my sister has cancer, and all of them have cancer before they are 50 years old, am I born to have cancer? Potentially, yes. But that only affects 5 to 10% of individuals. but we can also do something about it. If we know that we have a very strong family history, there is a key tool in recognizing those at risk, meaning a good family history. With that, we can do a genetic test, which is a blood test or a salivary test to see if we carry the gene that may predispose us to getting early cancers. And if we have that, we can do procedures to reduce the risk of cancer even before it happens. So individuals with very strong family history can undergo genetic counseling based on that and will benefit from intensive screening or preventative surgery. So can cancer be controlled? Of course it can. We must first know the symptoms of cancer. Some people know the symptoms of cancer and ignore it. If we know that there are symptoms of cancer, at least we can treat them earlier. So the symptoms of cancer is caution, change, or C for change in bowel or bladder habits, a sore that doesn't heal, unusual bleeding or discharge, thickening or lumps in the breast or elsewhere, indigestion, difficulty in swallowing, obvious changes in the mole, and a nagging cause of hoarseness. But as Dr. Lee has shared just now, by the time we have symptoms, it might already be an advanced stage. So if we want to do even better cancer screening or cancer prevention, we must start from risk factor control and cancer prevention, which I've shared before. And we must also do cancer screening, early treatment with a higher chance of cure and not needing a lot of treatment. Unfortunately, if we can only find it at a late cancer, we can still do early treatment, maintain the function, and prolong the survival because we have a lot of drugs that are available right now. So let's talk about cancer screening first. Cancer screening is checking for cancer in people with no symptoms. That's called screening. There have been several screening tests that has been shown, but the first thing is it must be affordable. It must be easy to get, and the cancer must be common enough so that we have a higher chance of getting it. It's no point screening for a very rare cancer using an extremely expensive procedure because it is not sustainable. However, despite having inexpensive screening techniques, because of fear, because people feel fine, because they're not at risk, because they have no time, it's maybe still too expensive, they don't want to go for screening. But the three main screening which is widely available is cervical pap smear, colonoscopy, which Dr. Lee has shared extensively just now, and mammogram and ultrasound screening. All these three procedures can cure cancer. It cannot prevent the cancer, but it can detect it at a very early stage, especially in a pre-cancerous stage. That means that these are developing pre-cancers. They have not yet become cancer. We screen it, we pick it up, we do simple treatment, they never have a chance of becoming cancer. But if we still end up having a cancer, we need a multidisciplinary team that involves a surgeon, a radiotherapy doctor, and a medical oncologist. Many patients come and see me and say, can you take out the tumor, give the radiotherapy, and do the chemotherapy at the same time? We used to, many years ago, perhaps in the 1970s. We do everything, all one-stop shop. However, because things for treatments are getting so complex that it is impossible for one person to know everything and to do everything. Therefore, we require a team effort to maximize the chance of cure, minimize the damage to a primary organ, prolong the life, and maintain the quality. So surgery is the most important first. Surgery requires the removal of the tumor, accurate diagnosis so that we can see what type of cancer we're dealing with. Sometimes we think a cancer in the liver is due to liver cancer, but it turns out to be a bile duct cancer. So a biopsy is important. When we have discovered what cancer it is, we then decide whether it's surgically removable. If it's not, then we institute radiation treatment and chemotherapy. Now, I put chemotherapy here as plants. You can see the periwinkle flower. You can see the leaves. These are toxic chemotherapies that we give is a one-size-fits-all. If it's CPT-11, we give it for colon cancer. If it's vincristine, we give it for lymphomas and leukemias. And paclitaxel, we give it for breast cancer, ovarian cancer, so on and so forth. But there are many different types of chemo aimed at curing the cancer, potentially eliminating the residual cancer before it settles, or palliative treatment that reduces the cancer burden. So this is the norm now. Before we advise any patient to go for surgery, we would shrink it and do a smaller surgery. This one on top on the left shows an ovarian cancer patient. The one at the bottom shows a breast cancer patient. And this one on the right shows a colorectal cancer patient who was cured of their stage 4 colon cancer. But we don't talk much about chemotherapy nowadays. We spend more time and more effort talking about the era of targeted and personalized therapy. Without precision medicine or target therapy, one size fits all. Anybody with the same type of cancer will get the same drug. But with precision medicine and target therapy, we say patients with the same type of cancers may potentially receive different treatments due to the genetic analysis of the tumor itself, called next generation sequencing, and potentially that can permit them to get tailored treatment that is more suitable and less toxic. So let's look at the Vietnam cancers. Dr. Lee has shared this before. All the cancers are going up. All the cancers are going up. I think that is more of a matter of better diagnosis, not because it's a true, real increase in the risk of cancer in Vietnam. In Vietnam, healthcare has improved a lot. Really, really, really tremendous improvement in the healthcare of Vietnam in the last 20 years. Because of that, more and more people are being diagnosed of cancer because the awareness is there. But we are going through this transition where we are diagnosing more cancer. We must also be able to cure more cancers. And that's what we need to catch up on. So in Vietnam, we have liver cancer, lung cancer, and breast cancer, stomach, colorectal, and the other cancers, about 40%. So if we look at lung cancer, the last time we know is just chemotherapy, and chemotherapy doesn't work very well. A patient with advanced lung cancer lives for 1 year, perhaps 2 if they're lucky, if they can't go for surgery. But now if we look at the personalized medicine in lung cancer, simply look at East Asian lung cancer, which is the Chinese, the Vietnamese, the Thai patients, the Hong Kong patients. All these are East Asian lung cancer that is not associated with smoking. Of course, we still see a lot of cancers that are associated with smoking, but there is a large group of women and men who has never smoked in their life, but they still get lung cancer. And these are the different types of treatments that are available. I can't even begin to read one by one by one. This is the number of lung cancer treatments that we have available. My partner in my clinic, Dr. Lim Hong Liang, says to me, nowadays lung cancer live potentially just as long as breast cancer. And we're talking about 10 years, 12 years, 15 years, no longer the 1 to 2 years. Non-small cell lung cancer, we bring all the tumors through a molecular profiling so that we know what are the best treatment, and then we can go from one treatment to another, to another, to another as the tumor mutates. What about pancreatic and gastric cancer? Similarly, what we have in algorithm, which means it's like different types of treatment, we have palliative treatment, which is HER2 negative, HER2 positive. All these are targeted therapies for pancreatic and gastric cancer. It is getting more and more and more complex. But we also know that some part of this complexity involves the immune treatment or immunotherapy, using our white cells to kill the cancer cells. What about targeted therapies for liver cancer? Again, if liver cancer cannot be cured because we didn't do screening and we didn't pick them up at an early stage, we can only go for targeted therapy. We used to only have one line of therapy. It's either that or nothing. Now we have second line, we have third line agents that can help to transform the treatment of liver cancer to a chronic disease. What about colorectal cancer? Similarly, for stage 4 colorectal cancer patients, we can outline what type of colorectal cancer they have and therefore provide the necessary targeted therapy. One big thing is this thing called the microsatellite instability, which is determination of an association between colorectal and womb cancer, where part of the patient group has a very strong family history. Not only can we use immunotherapy, use our white cells to fight against the cancer cells, we can also screen their family for the high risk in a genetic syndrome called HNPCC, where we can do surgery such as removal of the womb before a woman has the cancer, or intensive screening, or even removal of the colon and the rectum before a person has the risk of getting the cancer. What about ovarian cancer, breast cancer, and prostate cancer? Looking at 2014, which is 10 years ago, compared to now, these are the different types of developments in the genetic testing of cancers and the treatment of cancer using somatic or tumor testing. But most importantly, to survive cancer, this was quoted of a cancer survivor. She said that she was lucky that the cancer was caught before it spread. And we can only do that if we do screening. But we can only do screening if we have the knowledge that our cancer can be screened. And that's why I'm very happy to see all of you here, because you're here for the education, you're here to spread the word around that a cancer can be caught before it spread. She's also lucky, she said, that she had effective treatments available to her. Meaning, yes, if I found it early, what can I do about it? There's no point if I found it early and nothing can be done about it. The third thing is that she had excellent health insurance that paid for the treatment. Of course, all of us must have a compulsory, small little bit of insurance so that when we grow older and we get cancer, at least there's someone there to help us with the payments. But she realized of all the factors why she survived cancer was that she chose to treat her cancer aggressively rather than to sit there, not go for treatment, and let the cancer spread until she dies from it. With that, thank you very much.
So many thanks to Dr. See Hui Ti for your sharing to all of us and have us know more, have a better understanding about cancer, how to treat it and how to prevent it. So, ladies and gentlemen, today's sharing session will have two parts: the cancer prevention update on advanced treatment methods, as well as gastrointestinal healthcare and screening for digestive system cancer. So right after this, we would like to invite back to stage our special guest, Dr. See Hui Ti, as well as Dr. Jarrod Lee. And along with them, we also would like to invite Dr. Young Phong Gi, trip representative of Mount Elizabeth Hospital, Singapore in Vietnam, who joins on the stage to come to the Q&A session. Warmly welcome.
Xin chào quý quan khách. Nãy giờ quý quan khách nghe hai bác sĩ Lee với bác sĩ Si trình bày hai cái bài về ung thư đường tiêu hóa và tầm soát các cái loại bệnh ung thư, những nói sơ về những cái thuốc mới trong điều trị bệnh ung thư. Thì quý vị có câu hỏi nào thì ghi ra giấy hoặc là quý vị giơ tay thì tôi sẽ hỏi trực tiếp hai bác sĩ trên đây. Xin mời bác.
Hỏi bác sĩ là sau khi mà mình phẫu thuật rồi đó thì cái thời gian vàng để mà mình hóa trị và xạ trị là bao lâu?
Có hỏi cụ thể cái ung thư gì không ạ?
Dạ, ung thư ca đại tràng.
Thank you for the question. After colon cancer surgery, the best time to get the chemotherapy is anything between 3 to 6 weeks.
Cái thời gian vàng mà cô hỏi đó là sau khi cái bệnh ung thư đại tràng mà mổ xong rồi thì khoảng thời gian tốt nhất là 3 đến 6 tuần sau khi mổ. Cái lý do 3 đến 6 tuần là tại vì thứ nhất để cho cái vết thương nó lành hẳn đã. Tại vì cái thuốc đó mà truyền vào sớm mà cái vết thương chưa có lành á thì nó sẽ làm vết thương nó sẽ bị nó không có lành được.
Sometimes people are very concerned that the wound has not healed up yet. But if the wound hasn't healed up, we can still give the oral chemo part first.
Thành ra có những cái trường hợp mà trong cái thời gian 3 đến 6 tuần đó mà cái vết thương nó vẫn chưa có lành á thì người ta cho cái cũng là hóa trị nhưng mà cho cái đường uống trước.
Nếu mà sau qua cái giai đoạn thời gian vàng đó thì mình uống thuốc thì nó có hiệu quả không? Nghĩa là sau 6 tuần á.
Of course it is, yes. I mean, it's up to 3 months, but we asked the question, why did the patient was not able to? Was it because of wound issue? Was the patient unfit? If so, then there's no choice about it. But at least try and start within 3 months.
Thì nếu lỡ không có cái trường hợp nào mà mình không có hóa trị được trong vòng từ 3 đến 6 tuần đó, thí dụ như vết thương nó không lành hoặc có những lý do khác mình không có thể nào mình truyền thuốc được, thì cái đó mình phải chịu thôi, không có chọn lựa nào khác hết. Và cái hiệu quả nó cũng tốt như thường.
Nếu trễ hơn thì nó không có hiệu quả hả bác?
Hiệu quả
Vẫn hiệu quả
như thường.
Nhưng mà cái hiệu quả nó giảm không hay là nó vẫn vậy?
It's the same chemotherapy given, but of course, because the clinical trials show that it must be given within 6 weeks, no one can tell whether there's the same effectiveness as after 6 weeks. But it's better than not giving any chemotherapy at all.
Thành ra bây giờ người ta vẫn khuyên mình là làm sớm trong 3 đến 6 tuần. Còn nếu lỡ có chuyện gì làm sau 6 tuần thì cũng không sao. Tuy nhiên vì chị hỏi thì nó có cái nào tốt hơn, không có cái thông số về y khoa về cái chuyện đó. Tức là không có nói tốt hơn hay xấu hơn, mà vẫn có những lý do gì không vào được trong lúc 3 đến 6 tuần thì vô sau 6 tuần thôi. Chứ không phải sau 6 tuần mình vô nó không hiệu quả bằng lúc 3 đến 6 tuần.
Dạ xin hỏi bác sĩ, tại vì tôi có đứa cháu họ là cũng có trình độ nhất định, nhưng mà khi mà bị đi khám bác sĩ cứ là đau thượng vị, cứ nghĩ là tiêu hóa, cứ cho uống thuốc về hoài. Nhưng mà đến một lúc đó thì đến một thời gian nữa bác sĩ cho đi xét nghiệm mới phát hiện ra ung thư, thì lúc đó là đã di căn rồi. Thành ra là khi mà rồi sau đứa
ung thư gì vậy chị? Ung thư bao tử
trực tràng
hả?
Ung thư bao tử hay là đại tràng vậy đó. Tại vì đứa cháu đó chết cũng lâu rồi, thành ra là nghĩa là cái biểu hiện nó ban đầu là bác sĩ chỉ khám là đau bao tử đó. Thành ra như vậy đi thì họ hàng cũng sợ, cũng xem như ai cũng đi xét nghiệm rồi đi đại nội soi trực tràng. Như vậy nếu mà cứ đại nội soi trực tràng hoài như vậy đó thì sẽ phát hiện sớm được bị ung thư hay không?
Xin lỗi chị, cái người cháu của chị mất lúc cháu nó bao nhiêu tuổi gì?
45 tuổi.
Là cách đây bao lâu?
Cách đây 3 năm.
Rồi cái lần nội soi đại tràng cuối cùng của chị là hồi nào?
Cách đây 1 năm.
Thank you for the question. The treatment of colon polyps today is based on huge databases, and the research has been compiled over the last 30 years. So the interval to repeat the colonoscope depends firstly on the quality of the colonoscope, which includes the quality of the polypectomy. Now, assuming this was done according to the international standards, then the next colonoscope would depend on the size of the polyp as well as the number and the cell type. So for many of the precancerous polyps, if it was just 1 or 2 of the adenomas and they are less than 1 centimeter in size, a lot of countries will just repeat it at the 10-year mark. If it was a high-risk polyp, if it was big, the cell type is bad, we may sometimes want to repeat it within 3 years. Now, we only repeat it in 1 year if the polyp was not removed in one piece. That means it was removed in several pieces and we can't really tell whether it has been cleared, or if the doctor has got some doubts about how he removed that polyp and he wanted to come back in within a year to see whether it was fully resected. I think the last group of patients that we do at 1 year are those with very, very high risk of cancers, those with genetic syndromes. Thankfully, that is very rare.
Cái câu hỏi của chị đó thì như vậy nè, khi mà có một cái chẩn đoán mình soi vô mình thấy cái polyp ở trong đó rồi đó, thì thường là ví dụ như 1-2 cái nhỏ nhỏ thôi, và cái đường kính của một cái nó nhỏ hơn 1 cm. Thì thường bác sĩ lấy cái đó ra. Sau khi thử tế bào rồi á, thì thường nếu mà nó bình thường hết thì nó 10 năm sau mới làm lại một lần. Nhớ cái này, tại vì ở cái đó là chuẩn của quốc tế, còn ở những cái nước giống như mình thì có khi người ta không có theo cái chuẩn đó, vì cái lý do gì đó thì có biết được. Nhưng mà chuẩn của thế giới thì giống như nãy tôi nói á, thí dụ có 1-2 cái thôi và nó nhỏ, đường kính cái nó nhỏ hơn 1 cm, và thử cái tế bào ra không có gì hết. Sau khi người ta cắt ra nó, người ta thử tế bào tuyến bình thường thì cái đó người ta 10 năm sau mới làm lại. Trường hợp thứ hai là những cái polyp mà nó khả năng nó quá ác nhiều á, thí dụ như nhiều polyp và cái đường kính nó lớn, thử ra những cái tế bào nó có những cái loại nó tiền ung thư hay chẳng hạn như vậy thì có thể người ta cho mình làm lại mỗi 3 năm. Đó là cái chuẩn của thế giới. Những cái trường hợp mà 1 năm mà phải làm lại sau khi nội soi á, thì có những cái trường hợp đó là đa số là nhiều polyp và nó có mang tính chất di truyền, và cái loại tế bào nó cũng nó tiền ung thư mà nó cũng gần tới cái loạn sản dị sản ở trong rồi. Thì lúc đó bác sĩ mới quyết định làm cái chuyện đó. Thành ra bác sĩ Lee có nói là cái chuyện mà cái kết quả của nó phụ thuộc vào cái chất lượng của cái máy. Người ta quyết định cái chuyện mà lặp lại cái nội soi đại tràng là nó dựa vào những cái yếu tố, thí dụ như là kích thước của cái polyp và cái số lượng của polyp và cái loại tế bào của polyp. 3 cái đó người ta phân tích hết rồi người ta mới cho mình cái thời gian là bao lâu nên làm lại một lần. Thì cái nãy nó 10 năm, 3 năm, 1 năm là nãy tôi có giải thích, bác sĩ Lee có nói là tôi có dịch lại.
Tại vì bác sĩ phòng khám á, nói là mỗi năm phải làm lại một lần. Nhưng mà cái nhân viên ở chỗ đại nội soi trực tràng á, thì bảo là trời gì làm nhiều dữ vậy, 2 năm một lần là quá rồi. Đó, mà hôm nay là được nghe bác sĩ nói vậy nữa. Thành ra giờ cái băn khoăn á, là làm thế nào để cho yên tâm.
Dạ, chị mai chị cầm cái hồ sơ soi của chị á, chị gửi lên chỗ của bác sĩ á, để tí chị liên hệ với em này nè.
Vâng.
Chứ giờ chị nói vậy là cũng không có cái hồ sơ gì để coi hết ha.
Vâng.
Thành ra mai chị gửi lên rồi xem như thế nào.
Em muốn hỏi bác sĩ là cái kết quả chẩn đoán của sang thương tuyến vú mà BRAF 2 đến BRAF 3 và có một cái chẩn đoán khác của siêu âm ở bên bệnh viện ung bướu là tuyến vú bướu sợi tuyến vú thể giả bướu, sang thương tuyến vú lành tính thể giả bướu, thì nhưng mà ở vú có rất là xuất hiện nhiều nang, thì cái đó nó có làm tăng nguy cơ ung thư vú sau này không?
So yes, the BI-RADS system is a very subjective system, meaning I see with my eye, he sees with his eye, and he sees with his eye. It might be a 2 and a 3 and a 2. So it looks at the pattern of the calcification, and it can be very, very based on subjective opinion. So therefore, whether it's BI-RADS 2 or BI-RADS 3, there's not a lot of difference. Basically, BI-RADS 3 just tips over and says that we must have short follow-up because there are some very, very mildly suspicious nature of the calcification. Therefore, an earlier repeat must be done to see if there are further changes. Only if it's a BI-RADS 4 does it become 1 out of 4 chance it is cancerous. And if it's a BI-RADS 5, then it's cancer until proven otherwise. So BI-RADS 1 means regular follow-up, every 1 year, every 2 years. BI-RADS 2, regular follow-up, but look out for lumps. BI-RADS 3, short follow-up, 6 months down the road. BI-RADS 4, please biopsy. BI-RADS 5, definitely cancer until proven otherwise. So a BI-RADS 2 and a 3, it doesn't mean that it will develop into a cancer. It's just that the doctor who's reporting it right now can't really tell. So he wants another one in 6 months to compare.
Siêu âm mà vú mà có rất là nhiều nang như vậy á, thì là nó có ổn không ạ? Tức là nó có tăng nguy cơ ung thư sau này không? Tuyến vú có rất nhiều nang.
No, so fibrocystic condition is not a precursor of cancer. But the fact that there are changes in the breast means that this breast is very responsive to female hormones. 5% of fibrocystic condition can be associated with a cancer. 5%, which means 95% of the time there's nothing there. But a mammogram and an ultrasound is only accurate at the time that we do the scan. So, which means that can fibrocystic condition become cancer? No, it cannot. If it's fibrocystic, it's fibrocystic. If it's cancer, it's cancer. But right now, imagine the three of us are 5-year-old kids. You have no idea what we're going to be when we're 20 years old. But only at 20, then I say, oh, this one is going to be a doctor, this one's going to be a businessman. We don't know. But at the time, right, can we tell when we are 5 years old whether I'm going to be a doctor, he's going to be a doctor? We can't. Same thing with a fibrocystic condition and a cancer. Sometimes a fibrocystic condition can look like a cancer, but it's not. But a cancer at the very early stage can look like a fibrocystic condition.
Em muốn hỏi thêm một câu hỏi nữa là vừa rồi em có qua bên bệnh viện Mount Elizabeth, tại vì bạn em có một người thân là năm nay khoảng 39 tuổi, thì là thường trong khoảng sau khi mà bị Covid xong á, thì là hay trong vòng 1 năm vừa rồi kiểu tháng nào cũng bị viêm rồi sốt rồi viêm họng, kiểu nhiễm trùng đường hô hấp ấy. Xong rồi qua bên đó thì em có kiểm tra làm xét nghiệm máu lại ở bên bệnh viện Mount Elizabeth, thì có một cái kết quả ở trong cái xét nghiệm máu mà em chưa kịp hỏi bác sĩ ở bển, thì là nó có một chỉ số là LDH nó rất là cao, 298H. Thì em có search ở trên mạng thì nó nói về là tổn thương tế bào hay là hư hỏng tế bào gì đó, thì em không biết là nó có
LDH hồi nãy em đọc bao nhiêu?
298 ạ. Thì có phải như em search rằng là nó có liên quan đến mức độ tổn thương tế bào hay là hư hỏng gì đó, và tụi em có cần phải làm thêm cái kiểm tra xét nghiệm gì hay không?
Yeah. So LDH of 298 is not high. If we're talking about lymphomas and leukemias, it must be more than 1,000. 298 can be due to very non-specific infection, even in long COVID syndrome. So I would advise that she can just get that repeated in the next 3 to 6 months. Any infection can cause LDH to go up.
Xin hỏi bác sĩ là cái trường hợp nếu như mà phát hiện ung thư thời kỳ cuối á, nếu như mà chữa trị ở nước ngoài thì có khả năng sống lâu hơn hay khả năng sống lâu hơn?
Yeah, I think that's a very, very good question. Whether a person gets a better treatment in a local facility versus an international facility will depend, number one, on the understanding of the patient, first of all. It's not always possible to receive treatment in a country that they don't stay in. That's number one. If, let's say, treatments are the same, there are often a combination of a willing patient, a very tenacious and a very hard-going doctor to keep pushing treatment. And therefore, sometimes even in an international center, you can have a patient that lives 6 months and another patient with the same condition that lives 6 years. And another patient with the same condition that lives 16 years. So while this question is very general, it's extremely difficult to answer. Sometimes it depends on when we pick up the patient. If the patient is picked up at a late stage with very little tumor volume, little tumor burden, they can live a very, very long time, no matter where they are treated. But if we pick up a patient only when the cancer burden is extremely, extremely high, then no matter where the patient is treated, the survival will be short. So it's very tough question to answer.
Cho em hỏi thêm, nếu như ở trong nhà một người cha bị cái đó thì về sau con cháu hay là cái gì thì nó có cái gen di truyền gì không ạ?
Bị cái đó là bị cái gì?
Bị ung thư phổi.
So lung cancer rarely can run in the family, yes. But that lung cancer must be early. That means this gentleman must be a non-smoker who got lung cancer at the age of 50. And then there is another brother and another family member who has got lung cancer, female, again non-smoking. If father smoke, mother smoke, brother smoke, everybody smoke, and everybody gets cancer, then that's not due to the genes.
Dạ, Bác sĩ cho em hỏi thăm, vừa ở Việt Nam á, thường trong mấy gói khám tổng quát á, là bác sĩ hay cho làm xét nghiệm như CEA, rồi CEA 125 ung thư buồng trứng hay là CEA 199 á. Ví dụ ở nước ngoài những xét nghiệm nó có cần thiết để mà tầm soát sớm ung thư không? Rồi cái thứ hai là em hỏi bác sĩ Lee á, là những trường hợp mà để phát hiện sớm ung thư đại tràng á, thì có nên là nội soi đại tràng ở lứa tuổi nào tốt nhất á? Ví dụ trên 40 tuổi hay là gì? Rồi cái thứ ba là có những bạn mà em có gặp một bệnh nhân là bé này 16 tuổi nhưng mà cái nội soi đại tràng là có đa polyp gia đình á, đa polyp á, thì những gặp cái trường hợp mà bệnh nhân trẻ mà bị đa polyp á, thì có tầm soát hết gia đình không? Rồi cái thời gian tầm soát là bao lâu để mình phát hiện coi có ung thư đại tràng mà dạng đa polyp không vậy? Em xin cảm ơn.
Chị nói cái đa polyp đó là đa polyp đại tràng đó phải
Đa
không?
polyp đại tràng, dạ.
Okay, there's a two question.
A tumor marker was developed to mark a tumor that is there. So if the tumor isn't there, or it's pre-cancer, meaning it hasn't become an advanced cancer, then the tumor marker cannot pick up a cancer. So tumor markers are not good for screening cancers. In fact, sometimes we see a higher tumor marker in benign conditions such as gallstones, gallbladder infection, uterine endometrial polyps, uterine fibroids. All these can cause the tumor marker to go up. However, if we are just simply going for a cancer screening and we did the tumor markers and the tumor markers were very high, then there is a high chance that this person has cancer, except that it will not be in the early stages, it will be in the advanced stages. So the whole point of cancer screening is to find them early. But if I don't have any symptoms and I go and do my tumor markers and it happens to be high, I can still look for cancer and treat them early. It would just not likely to be early stages.
Câu số 2 hồi nãy chị có hỏi rồi đó, để bác sĩ Lee sẽ trả lời câu đó.
So the question is, what is the best age for GI scope for polypectomies? So the best age to go for a scope, the international recommendation in many countries in the world today is to start your first colonoscope at the age of 50 if you don't have any family history or risk factors. In the last 5 years, the Americans have advocated age of 45 to start because they have noticed that more and more young Americans are getting colon cancer. But this recommendation to start at 45 years is only by the Americans. The rest of the world have not really followed this yet. If you have family history, then you should start at the age of 40 or 10 years younger than the person who had the cancer. So if a family member has cancer at the age of 42, then you start your scope at 32. Stomach cancer is a lot more controversial, and it really depends on the population that we are talking about. So in certain countries where there is a very high number of stomach cancer patients, they may want to start at 40. Some countries may start at 45. Some countries start at 50. Again, this is very controversial. I think that with the better imaging that we have, we are starting to identify patients who are at higher risk of stomach cancer based on an initial scope. And then we can start to say whether we do it every 3 years or 5 years, and so on and so forth. Now, if a patient has polyposis syndrome, then that's a different story. If you have certain types of polyposis syndrome, you may have to do your endoscopy every 1 to 2 years, depending on what syndrome it is. Thankfully, these are very rare.
Xin chào các bác sĩ, cho tôi hỏi là gia đình tôi có người ruột thịt đấy là bị ung thư gan giai đoạn 3 đấy, và đã mổ một lần đầu mổ banh, và lần thứ hai thì mổ gọn hơn là cách có 1 tháng. Thế bây giờ thì bác sĩ cho theo dõi là 2 tháng 20 ngày nữa thì đi kiểm tra lại. Thế thì phương pháp chữa tiếp là thế nào? Và trong gia đình có cần đi kiểm tra tầm soát hết lại cái ung thư gan không?
Yes, thank you for that question. Your question is very personal, and there are no details at all. May I encourage Dr. Nee to help you to send the question to us, and we'll give you a more detailed reply.
Chị, mấy cái câu hỏi mà nó đi sâu như vậy thì cần những cái dữ liệu. Chứ không có một cái bệnh nhân ung thư gan thì không có, mỗi người mỗi khác, không có nói chung chung nếu không có dữ liệu. Thành ra chị ghi cái số này lại giùm em nè, 0983 949 702. Thì sau đó chị 0983 0983 949 702 là cái số của tôi á. Bên chị gửi, và tôi tên Nghi. Cái bên chị có thể gửi bằng Zalo hay là Viber á, những cái hồ sơ của mình á, gửi lên đó. Bên bác sĩ bên Singapore người ta coi cái đó không có tốn tiền nha. Dạ chị cứ ấy, tại vì cái đó nó sâu. Dạ nghi.
Actually, yes, you brought up a really, really interesting point. Anyone who has a family history of gastric cancer should get a scope done. Everyone in the family should get H. pylori screened, and anyone with a family history of liver cancer should get screened for liver cancer and hepatitis B and C. Yes, absolutely. And that was the question I wanted to share with Dr. Lee here. You know, in Vietnam, we have a very high chance of hepatitis B infection, carrier status, as well as Helicobacter pylori infection, multiple, recurrent, recalcitrant, stubborn infections. What advice do you have for our Vietnamese audience here?
I think for hepatitis B today, with the science that we have, nobody should be getting liver cancer from hepatitis B. In the first instance, you should vaccinate. That means you don't even have it. And if you do have hepatitis B, you should be seeing your doctor every 6 months for regular follow-up. Today we have very good medication with practically no side effects. And with this medication, we can contain the hepatitis B so that nobody today with hepatitis B should get liver cancer or liver cirrhosis. Helicobacter is a trickier question to answer because the success rate of treatment is not 100%. But it is important to treat the Helicobacter. Although this is still a bit controversial, but many scientists think that the initial infection is the most important one. And the initial infection is the one that causes a lot of stomach changes. So the normal stomach starts to become atrophic or weaken, and then you start to have changes in the cells in the stomach. Today, a lot of gastroenterologists, they subscribe to this idea of the point of no return. And if we see a patient and we eradicate the Helicobacter before the point of no return, then that patient's stomach cancer risk will be about the same as the general population. But if we miss that point of no return and we only eradicate it after, then that patient's stomach cancer risk is thought to be permanently increased. And that patient will then have to go for regular surveillance for early detection. So it's no longer prevention, it's about early detection.
I think with liver cancer and with stomach cancer, we used to think colon cancer could be prevented by simply doing polypectomy. We now firmly believe that stomach cancer can be prevented by eradication of Helicobacter pylori, or at least control or find it early. The unfortunate thing is that in Asia population, in Singapore included, but more so in Vietnam, that we're seeing very young people getting infections early on and not knowing, and having chronic stomach issues and eventually getting stomach cancer when they're in their 40s or 50s. Similarly, for hepatitis B, we believe that everyone gets vaccinated, but not everyone manages to seroconvert, meaning if my mother had hepatitis B, my grandmother had hepatitis B, I'm born with hepatitis B, sometimes I become a carrier despite my vaccinations. So in that, I still have to be actively followed up to make sure that there are no appearances of curable liver cancers where surgery simply can be done. So all these, it's not true that we cannot. Breast cancer, we can prevent through diet. Cervical cancer we can prevent through vaccinations. Hepatitis B we can prevent through vaccinations. Liver cancer we can prevent through active screening. Colon cancer, stomach cancer can be actively prevented or treated early if we find it early. Lung cancer now, if you say every cancer can, but I'm worried about lung cancer, what can I do? We can even have a low-dose CT scan screening in order to find the lung cancer early for smokers. So there is actually no excuse to say that cancer cannot be prevented, cannot be screened, and cannot be treated. But yes, the lady asked this question, what happens if we go to an international center? It's not about whether it's international or about local. It's about the knowledge in here and the heart to want to do it. So if you have the knowledge that you can do it and the heart that you want to do it, then it's important to just go get it done. It's not about here or where. If you have any questions that are very complex that's regarding a family member or yourself about a medical condition, it's very difficult for us to share the answer because this video will be broadcasted all through Vietnam, and I don't think it's very nice for us to broadcast the answers. So please approach Dr. Ni and he'll help you. Thank you.
So thank you so much to our expert for the wonderful and insightful sharing to all of us. And right now we also would like to invite Dr. See Hui Ti and Dr. Jarrod Lee will stay on the stage. We also have the flower as our sincere thank to all of you. So right now we also would like to invite Miss Nguyễn Đỗ Quyên, Chief Officer Operation of FPT Long Châu, will join us on stage to give the flower for our expert.